have, okay, so thank you for joining us. This will be kind of informal. We have Emily Brown and Amanda Van Bremen are going to talk about hand hygiene in the hospital setting. And then Zach and Chandra are going to talk about, oh, it just went right out of my head, nursing shortage and implementation of patient ratios. So I do believe that Chandra and Zach, you guys are going to go first. So have at it, take it away.
What we addressed through our research from evidence-based practice this semester was the nursing shortage and implementing patient ratios on our units at UPMC Mercy.
Hello everyone, my name is Chandra and I'm a senior nursing student. And like Zach said, we researched our capstone project on nursing shortage, and the problem statement, meaning the problems we found were with the current shortage of nurses, it led to an increase in missed patient care, like providing patients with morning care or like providing their medications that not being on time, which could lead to an error and a higher risk of infections like CODI and CLABSI. And it also affect nurses with higher patient to nurse ratio that leave the nurses overwhelmed. And in our research, we found that correlation between higher ratio and missed patient care, and establishing a concrete safe nurse to patient ratios will keep nurses and patient safe, and also allowing a transition period for units understaffed to get appropriate staff can help with providing patients with high quality of care safely. And our focus question was, will establishing a concrete nurse to patient ratio that is safe improve patient and patient safety outcomes while also decreasing nursing burnout? And evidence of problems we found out in our research is, like I mentioned, correlation between higher nurse to patient ratio and missed care was very prevalent, which involved missing morning medications, over and under medicating the patients, and higher infection rates. And safe ratios led to reduced mortality, less medication errors, and a decrease in ulcer infection and restraint use. And nurse burnout has increased with the unsafe ratio. So like I mentioned, when nurses are provided with the right amount of patients, there was a positive outcome, which was reduced mortality. And patient safe satisfaction was poor when ratios were high, which makes sense because if they are not receiving the time and the care they should be provided with, they are not going to be satisfied. And this finding is really concerning, which is with an average of 5.4 patients per shift, mortality rate increased to 16%. And this is very scary because when doing my clinical practicum, I have seen nurses with 7 to 8 patients assigned daily, which means based on the research that the mortality rate could be even higher.
And Jacque isn't here to share this, but she had actually mentioned as well that on her unit for practicum, they have closed beds on her unit, but nurses on her patients were still at times seeing up to 10 patients in their daily patient assignments.
And along with that, prior studies showed that, like I mentioned, low nurse staffing levels were associated with higher reports of miscare, higher staffings were associated with reduced mortality, medications error, ulcer, restraint use, and infections. And low staffing results in difficult working conditions like heavy workload, lack of support and development for the nurses, and stress, physical, mental, and medical risk. And over half of the patients admitted to leaving some activities unfinished, and there was significant correlation between unfinished care and the nursing practice environment, as well as providing high quality of care. And the mortality rate for patient increased by 16% for each patient in the nurse workload. And now Zach will talk about recommendations, implementation, and the evaluation plan.
What we had recommended is a goal to appeal for strict nurse to patient ratios that would be used in units throughout in order to provide the highest quality of care. Oh, excuse me. It just went ahead there. In order to help prevent and decrease the rate of mortality, error, and burnout among the staff. Our implementation plan, in order to reach the ratio goal of 1 nurse per every 4 patients on a med-surg floor, or 1 nurse per every 2 patients on an ICU floor. In order to do this, first, the unit manager or administrator should gather and analyze the data relating to their current unit census, and they should determine the average patient to nurse ratio that they're working with at the beginning of this program. They should also be gathering data relating to the quality of care that's being provided to the patients. Different reports that they could look at are incident reports. They will also be observing the rates at which CAUTIs and CLABSIs occur on the unit. They will also be observing the rates of falls on the unit, and as well the occurrence of pressure injuries. And they should also, with that, assess the job satisfaction of the nurses working on the unit. From there, they're going to determine the staffing needs and post job openings for how many positions they would need in order to maintain a safe nurse to patient ratio on their unit. And with this, the nurses should have an understanding that this responsibility is not something just bared by the unit directors and administrators within the facility. We encourage that the unit directors are informing the nurses that they're going through this transitional phase and encouraging the current staff to recruit nurses that they know to come work on the unit. And while this application and interview process begins, the unit directors should either close, less preferably, close beds, or to employ agency nurses in order to maintain the safe patient ratios during this transitional phase. And this is just to decrease nurse burnout in the interim and ensure that the nurses are providing safe and high quality care to the patients. The unit directors should then consider unit-based activities outside of the clinical setting in order to increase morale among the current staff. Now, this is something that perhaps would not be viewed as something as incredibly important, but we believed that if the unit managers and administrators begin to carry out different activities outside of the unit, that this has the potential to build a sense of camaraderie and teamwork among the nursing staff. And that in itself has the potential to improve staff satisfaction tremendously. The unit directors should then provide education sessions relating to orienting and precepting newly employed nurses. And now this is something that at times current staff may not be open to. So it's important that the unit managers begin to offer incentives such as a shift differential for volunteering to train new nurses. And so after they've taken those classes on how to precept and orient new nurses through the education department, they would then be more likely and actually enjoy orienting a new nurse on the unit. And as I mentioned, safe patient ratios should be maintained preferably through the use of agency nurses or less preferably bed closures until the unit reaches the required amount of nurses to ensure safe patient ratios with each shift. Once the unit meets the staffing threshold in order to maintain safe patient ratios and the staff has fully and adequately been trained, the unit may reopen temporary closed beds if they have chosen to do so. As part of evaluation, it's important that the unit managers compare the staffing and unit census rates to the initial baseline data that they've gathered. Goal setting relating to how many nurses the unit must employ is essential because after they begin to evaluate, they may realize, we still need 1 or 2 more nurses. And it's at that point that it's important that the unit directors emphasize that nurses carry just as much weight in this recruitment and transition process as the administrators do. The unit administrator will then proceed by assessing and evaluating the job satisfaction on the nurses working on the unit. One thing that we had discussed was the implementation of an intervention called monthly staff rounding, and I'll discuss that in the next slide. The unit directors will then evaluate the occurrence of sentinel events as we've discussed of such CAUTIs, CLABSIs, fall rates, the occurrence of medication errors, as well as the occurrence of pressure injuries. They should anticipate and hopefully note at the end of this transition phase a decrease in the occurrence of infection and also incident reports that are filed. As we all know, safe staffing ratios have been a part of an ongoing conversation in the nursing profession. We've all been taught since the beginning of our curriculum that America unfortunately does face a staffing shortage. And this plan that we've set forth does not necessarily resolve the ongoing nursing shortage that we face, but instead addresses the short staffing issues of one unit in specific or one facility. It's essential that this conversation is ongoing on a unit scale between unit leadership and nurses employed on the unit, as checking in with the staff and addressing their work concerns has significant potential to increase job satisfaction among the staff. And this is where I had mentioned we discussed the implementation of monthly staffing rounds. And this is something that I've observed on my unit, where the unit managers will check in with the nurses and check in with other staff on the unit and address their concerns. They'll ask them, what do you feel has gone well over the last month? Are there any concerns you have with providing care to the patients? And then more specifically, as it relates to our project, do they feel that the unit has been adequately staffed to maintain safe patient ratios on a day-to-day basis? And it's important to note that this conversation is not just important on the units. It's important everywhere. It's important system-wide that the nurses and administrators continue to have this conversation as to how they can address staffing concerns. Now, this potentially could resolve the nursing shortage with us just continuing to keep the conversation going with nurses and administrators working alongside one another and pitching potential resolutions to solving the staffing issues and shortage. And now we will open the room to any questions you guys may have.
Great job. I think Dr. Nash has a question.
Hi, everyone. That was a very nice presentation. Obviously, a very important issue to be addressed in a very complicated situation, only be made more complex through COVID over the last 2 years. I do think one of the positives it has brought this to the attention of pretty much the whole country. I just wondered, I have 2 questions. One, I wondered what your thoughts were with any, I guess I should say resolution to how the discrepancies, I guess, with salaries between the agency and you don't have to, you could probably find this out on your first day of clinical, that's a traveler, that's an agency nurse, and they're making triple my salary. I'm working beside them doing the same job. So any thoughts on that in terms of, do you think increasing the salaries of the staff nurses is a better option than closing beds or?
Absolutely. Yeah, and it's a hard issue to navigate, absolutely, because as you've mentioned, agency nurses do get paid a good deal of money in comparison to the staff nurses that are employed on the unit. And that has significant potential in itself for the current staff to see a decrease in morale for their work. They don't feel that they're valued as much as the agency nurses are on the unit. And something that I've seen at UPMC or I've heard of is that the staff nurses are seeing an increase in salary bigger than they have seen within their career. I was actually having this conversation with my unit director at UPMC Shadyside, as well as with the unit director where I'm having my practicum. And she had said that staff nurses are seeing raises of upwards from 10 to 15% of their original pay, which is something tremendous. And one thing that I actually see a concern in as well is that new nurses who are becoming employed are being offered a sign-on bonus, as well as some other bonuses that are quite advantageous as well. But the question comes in, how do we distribute these bonuses to the staff in a fair and equitable way? Because to my knowledge, these bonuses are something that unfortunately are not being offered to the current staff. And so
Right.
It's a difficult thing to navigate, absolutely. And I think just with these staff nurses maintaining an open conversation with their administrators as to what they feel would make them feel valued on a day-to-day basis at work is how
Right.
we begin to solve this issue.
And I commend you for bringing that up, because as a very old nurse with many, many years of bedside and, different units, I really do think, this is going to sound like maybe an old person comment, but I really do think that overall the unit directors' jobs have changed so much and they just became more removed from patient care. And when I think back on my career as a staff nurse, the times that I worked under a unit director or manager that, was visible on the unit, you felt you could walk into their office and talk to them, or they were, they knew what was going on. That makes a big difference. And
Absolutely.
then, yeah, so when I heard you talking about that being available in the monthly check-ins and all that, that certainly goes a long way. So hopefully those tides are turning. And then the other thing, the biggest thing, I think, to sort of fix the problem going forward instead of all the Band-Aids, is we really need to do our part as nurses as a profession and get our, ANA, American Nurses Association, and any lobbying efforts, voting efforts to really get something in legislation. Because unfortunately, that's the only thing that sticks as a permanent change. I've seen hospitals with, unionize, and they have to pay a fine if they go over ratio or whatever that is. It's sort of, California was the one state that did the mandated ratios, but that didn't exactly get implemented well. And so room to go with that. But I do think at least we have the attention now of a lot of people outside of nursing are aware of the situation and really the value of nurses. Can't have a unit open if you don't have nurses taking care of the patients and recruiting people into the profession. That's, as you were talking about, just recruiting someone to come work on your unit because you're having a positive experience. That's what it comes down to.
Absolutely. And something that we had actually also found in our research was in 2017, there was a House bill proposed to the Pennsylvania Senate that proposed mandated patient ratios. And as I'm sure we are all aware, unfortunately, that bill did not pass into legislation. But I am hopeful and curious to see if future bills will come forward after we've experienced this pandemic.
Right.
Thank you guys so much, and thank you for all your questions. We are out of time for the first group. So I just need to kind of move on to Amanda Van Bremen and Emily Brown's discussion about hand hygiene. Now, I do need to pull it up on the screen. So Zach, I think you need to give me access.
Okay.
Uh,
I'm
wait,
sorry, I don't use Zoom all too often, so I'll see how to get my
You are
screen.
the co-host, Dr. Huber, you are the co-host, so you may have access to sharing anything.
I'm sorry, I didn't hear that.
I think you may have access if you need to share something.
Yeah, I did get it. Now,
Okay.
I'm just going to pull up this PowerPoint and share my screen here. Bear with me. Okay. Can you, those of you who are online, can you see this okay?
We can see, okay.
Okay, fantastic. Okay, so I'm going to turn it over to Amanda and Emily. You guys have about 15, 20 minutes.
All right. Hi, everyone. My name is Amanda, and this is Emily. We did our capstone project on hand hygiene. So we are actually on both. We're in the same hospital, but we're on 2 different units. So whenever we had to think about what was occurring on our units so that we could work together, the first thing that kind of came to mind and that we both observed was hand hygiene issues among the nurses and honestly just the staff in general. So this is what our project's going to be on. Hello, my name is. Sorry, I was recording on this. All right, so our problem statement is nursing staff on medical surgical units lack knowledge regarding appropriate hand hygiene practices and the link to healthcare associated infections. So basically we found that the nursing staff don't really recognize the fact that the healthcare associated infections are increasing because of poor hand hygiene practices. For the purposes of our project, we weren't able to share the unit statistics, but on my unit, they increased over the last couple of months from 0 cauties for a year pre-COVID to 2 or 3 a month. So it was really a big increase. And we just found that it was because of a lack of knowledge of the hand hygiene that can increase the HAIs. Multimodal education may increase knowledge of compliance. So we kind of just thought educating the nurses better would increase their knowledge about hand hygiene, and then maybe having that knowledge, they'll be more mindful to wash their hands. And then obviously increased healthcare costs for the patient and hospital due to the HAIs. So not only will the hospital have to cover the cost if it's associated from the nursing staff perspective, but then also if the patient gets discharged and readmitted within 30 days, the hospital will have to cover the costs of that. All right, so our overall focus question was, will multimodal education regarding hand hygiene practices and the link to healthcare associated infections increase hand hygiene compliance among nursing staff? So we just wanted to see if we implemented education among the unit about hand hygiene to see if it would decrease the healthcare associated infections from the hand hygiene. So the evidence of the problem, we found that 68% of nurses reported spending 80% or more of their time performing direct patient care. So obviously we know as nurses that we're with the patients like all day long. We have to wash our hands in and out of the room. It seems very tedious and annoying, but it's very important to kill that bacteria that lives on our hands. Through research, 85% had familiarity with the hand hygiene practices. So nurses are aware of it, but they're just not doing what they're supposed to be doing. 84% participated in a hospital-led hand hygiene initiative. And through observation, 59.1% reported hand hygiene on entering a room and 68% reported hand hygiene when exiting a room. So obviously this is a very low number for hand hygiene. I guess it is a good thing that the hand hygiene increases when they exit a room, because you're thinking like, oh, they just touched the patient. Whereas like maybe if you're from the computer going into the room, but obviously it's still very important no matter what to do hand hygiene both in and out of the room. So then we found lots of literature on this problem, which is a good thing, but also with so much literature, I feel like this should not be really an issue anymore. But single and combined interventions obviously improve hand hygiene among the nurses. Hand hygiene is the most effective measure to prevent healthcare associated infections, but compliance remains low. And we found that with COVID, it's really low because of the short staffing that we just talked about. Nurses are very overwhelmed, busy. They have stuff to do, they need to get it done. They're like, I don't have time to wash my hands. So they don't do that. And then obviously bacteria spreads and we get these infections. So increasing in-service training for professionals on the transmission of microorganisms in primary healthcare will ensure adequate level of knowledge among the nursing staff. We found that in-person training on how and when to appropriately complete hand hygiene can increase understanding among the nurses. So again, while this feels like a basic knowledge, it still lacks, and people can easily forget about how hand hygiene is the #1 like prevention in all these illnesses. So kind of starts with the hand hygiene. And then understanding the determinants of hand hygiene adoption is crucial for improving current practices and reducing healthcare associated infection rates in hospital care. And then some more literature that we found. So environmental strategies and organizational communication strategies could raise awareness on healthcare associated infection prevention and adoption of hand hygiene guidelines. We would want to include single intervention and multimodal studies to achieve positive increases in hand hygiene compliance across the healthcare system. So again, we both run different units, but we both observe the same problem against our different units, which is unfortunate, but this is why we are doing our project on this. So thorough hand hygiene reduces the risk of healthcare associated infections, which will ultimately decrease the cost of care and length of stay for the patient. Obviously, no one wants to be in the hospital, and then once they get an infection, they're in the hospital for longer, they need more antibiotics, treatment, increased costs, increased frustration, stress, just keeps piling on. And then effective hand hygiene among nurses can be directed at improving communication openness, considering the impact of perceived performance by peers, increase interactions with patients and staff, and determine how to reduce the stress and cognitive load that is associated with role performance. So again, a lot of this that we found for our research for the past 2 years is COVID really decreased hand hygiene compliance because of understaffing, they're stressed, they forget about it, they're going in and out of these rooms, but being in all these isolation rooms, it's really important to stop, wash your hands with soap and water, use alcohol rub your hands together until it's dry, not just half do it, hands soaking wet, and then move on. So Emily's going to take over from here.
So our recommendation was to determine if education related to hand hygiene will decrease the healthcare associated infections due to the hand hygiene compliance. And in order to implement our plan, we plan to discuss hand hygiene during morning huddle when all of the nurses are coming together to discuss any issues that are occurring. At this time, we would want to first make sure they're aware of what is occurring due to the poor compliance, such as the increase in the healthcare associated infections over the 2-month time span, the HCA-HPS scores from 2021 to 2022 to show the trending downward, as well as hand hygiene compliance over the last few months to better understand those percentages. As Amanda said, education really should be multimodal, so verbal demonstration, maybe the online modules we're very used to obviously is not the only thing that works. We need to see the physical demonstration, teach back methods to better understand. So we would want to implement both verbal and physical demonstration in which we talk about the 5 moments of hand hygiene, the appropriate scrub time, when to use soap versus the alcohol-based scrubs, and just a general technique. As Amanda said, a lot of times we kind of forget that. We just quick go and move on, but there's really should be more in depth to ensure we're truly getting the cleanliness that is needed. We also would like to send some education to the patients and family members and reiterate that they are able to ask if they are seeing their nurses or other staff members not completing hand hygiene, and they're able to do so at there's nothing against them if they're doing that. So in order to evaluate this implementation, we would then be comparing the healthcare associated infection rates, the HCA-HPS scores, and hand compliance percentiles, both before and after implementation. We would like to do this via some graphs that are showing trends to better show that comparison. We were doing so from January until the end of April. A lot of times they do them in month to like 3-month time span, so that kind of give us a general idea and then know what may need added to the education for better understanding. Further, we would like to interview the patients and staff to explore kind of their thoughts and how adequately performing hand hygiene practices have been done, as well as administering a simple 5-question quiz to staff members to demonstrate their knowledge. And this could be questions like I mentioned before, just the 5 moments of hand hygiene, the scrub time, when to use the alcohol-based scrub versus soap, and just general technique. Another thing we want to see are the staff members actually performing the hand hygiene to see if there's just maybe a disconnect between the verbal or visual information and how they are performing the hand hygiene as well.
And just from that, on my unit, they showed like trends for each month for the hand hygiene compliance of people monitoring it. And in December, I think it was like 75% compliance, which is pretty good for, especially being the winter months when everything kicks up and really illnesses are spreading. But then in March, it went down to like 29%, which is really low. So obviously that's a concern. Like, yeah, the COVID cases are dropping, but we still need to really be mindful and wash our hands.
So just to kind of reiterate some of the topics, nurses are the ones who are providing the most patient care. As Amanda stated earlier, about 80% of their time is spent in direct patient care, sometimes probably even more than that. So increasing hand hygiene compliance among nurses can better help decrease healthcare associated infections, and those decrease in the healthcare associated infections can lead to better patient outcomes, shorter lengths of stay, and decreased cost in the hospital system. So we'd just like to open up now for any questions regarding our project.
Great job. You highlighted the 29% sounds more accurate to me than the 75%. When you said that, I was kind of like, wow, that seems really high, just based on what I know about hand hygiene in the hospital.
And I don't remember all of the numbers over like that 4 or 5 months time span, but it just.
Yeah, level off, like.
So I'm kind of thinking there was a time where someone was pushing it a little bit more, so everyone kind of went up because they knew they're being watched.
Yeah. Yeah, so what do you think, I like how you highlighted, can you think of anything else? Amanda, I know you talked about COVID and those kinds of things and people being more mindful. That's probably why they have the 75%. And then can you think of any other reasons other than illness getting better? Can you think of anything that maybe contributed to that drop off, like you said?
Like to the poor hand hygiene
Yeah.
units. Honestly, I think a mixture between like the warmer weather and people thinking like bacteria is no longer a thing. But also on my unit, we've had obviously everywhere, but we have had really bad like staffing issues with people leaving. I was about to get my third preceptor
Wow.
in a span of 2 months. The very first day I showed up at the unit to precept, my nurse goes, "Oh, I'm leaving in like 2 weeks." I was like, "Oh, okay." Well, then literally everyone just dropped like flies.
Sure.
And then at one point, like I never had interaction with the unit directors. So like we talked about earlier, like I don't see them present on the floor, but the charge nurse, the few times I was there, she was actually really helpful. And she like would point out things like if your mask fell down below your nose, she's like, put your mask up. So she was very like open to like saying, hey, do this. Whereas I think a lot of people aren't willing to speak up and be like, hey, you need to do this.
Sure.
But also, I didn't mention this, but I had observed for my one shift before we had started our project, there were 6 nurses on the unit, and I only seen one perform hand hygiene when she went in and out. The other nurses, like, this is awful, but my nurse included, walked right in the room, no hand hygiene, walked out of the room, no hand hygiene. And then another thing that really triggered me, like I guess you call me a germaphobe, I'm always washing my hands, but like my nurse was helping me like clean up a patient who had soiled the bed and her phone rang. And while she was helping to wake him up, she answered her phone.
I think you told me about this, yeah, with the
And-
gloves on.
And I see this
Oh,
too
no.
often. And I just cringe because then she literally went on her computer to look up whatever with those gloves on. And then halfway through, she takes them off, but she doesn't wipe off the couch. She doesn't wipe off
After
the
she
phone.
had cleaned someone?
Yeah, and then she left me to clean up the patient myself. And this patient was very sick. So it was just like,
Oh, no.
this is why we have these issues. And then,
Yeah, mindless, it's just
Yes,
mindless.
yes.
You just do things without
Yes.
thinking
and then
about it.
another thing too is like, I see these nurses who are cleaning up the patients do this with their mask. And I'm like, you're not going to change that mask. You're going to wear that mask for 3 more shifts. Like,
Ugh,
this is why we
Yeah,
keep
that's
getting
pretty
everything
disgusting.
spread.
gross.
And then again, like with the whole alcohol-based hand rub, my nurse always, all right, let's move on to the next thing. She's typing away, but you didn't really
It's
scrub.
not
so
dry.
yeah,
Yeah,
so everything's wet and your hands actually aren't clean. So I was always having to take time to like go to the sink in the hallway, wash my hands because I just felt gross. Like,
yeah,
Yeah.
so I just think like hand hygiene like is so important. Like
Yeah.
it's one of the main things to help prevent the spread of all this. Like it's basic and we need to do this so badly.
agreed.
back to the basics.
Yes.
Agreed. Does anybody online have any questions or comments for Amanda and Emily?
I just have a comment. This is Dr. Nash again. Do you still see the signs that for the patients and families, like remind your nurse or don't be afraid to ask your nurse or provider to wash their hands? Have you ever seen those?
I do believe there are supposed to be signs. I personally did not recognize any signs. There are also supposed to be the signs that remind you of the 5 moments of hand hygiene, which I've seen like a couple, but they're not even really near the sink or hand sanitizer where you
Right.
think they should be. So that's why I think they're kind of reiterating all of that to patients and family members and having those signages available or just other simple ways to be able to set those reminders.
Right, because hopefully if you were thinking of taking that shortcut and that sign was there, you're like, I'll feel really embarrassed if the patient has to ask me to wash my hands, but maybe not. Nice
Yeah,
job.
I honestly haven't seen any of those signs around on my
I
unit.
haven't either.
But whenever we were doing like research, it was nice to see like the right to ask. Like I hadn't really heard about that until we did this. With like people being like, encourage the patient to ask, hey, did you wash your hands? Because I think patients are like, oh, the nurse knows what they're doing. Like I don't have to question them. But I think it's really important that the patient does question us because if you have 10 patients, you're going to be flustered and you're going to be like, oh my gosh, I have to do this and this and this. And then you forget. So I just think it is really important to like teach our patients, like, yes, question me. I want you to question what I'm doing.
Yeah, good. Very good,
job.
yes.
Thank you.
Thank you so much. And our third presenter was to be Mackenzie Perry, but I guess something came up and she wasn't able to present. So for those of you who are online, thank you so much for coming and participating. Have a great day. Thank you very much.
Thank you, everyone.
Bye-bye.
Thank you. Great presentation, guys.
Great work to all.